Welcome, and thank you for joining us for our first webinar in the NCARE webinar series. Our agenda today is we will do a quick welcome and an overview of Initiative for Research and Education to Advance Community Health, also known as IREACH, and Partnerships for Native Health. And then we will roll into our presentation, which is harm reduction talking circles for urban American Indians and Alaska Natives with alcohol use disorder, presented by Dr. Lonnie Nelson and Dr. Susan Collins, with a special guest, Sean Buffalo Mead. We will close with a brief 10-minute question and answer, and then 24 hours after the event, we will send a survey link to all participants. At the Initiative for Research and Education to Advance Community Health, known as IREACH, we challenge the status quo and advance community health through partnerships and collaboration. IREACH is a larger research department within WSU that consists of six schools, the College of Medicine, the College of Nursing, College of Pharmacy, College of Engineering and Architecture, the College of Communication, and the College of Veterinary Medicine, focusing on the health needs of 5 unique populations: rural health networks with Justin Denny, Native Hawaiian and Pacific Islander health with Kaimi Sinclair, Latino health with Anna Zamora Kapoor, and addiction studies with Michael McDonald. We also have Partnerships for Native Health with Lonnie Nelson. At Partnerships for Native Health, we conduct community-based research and education to improve health and reduce health disparities among American Indians, Alaska Natives, Native Hawaiians, and Pacific Islanders. The center is a prototype for program development for new and novel programs at Washington State University. We also focus on achieving health equity, community outreach engagement, and training and education. We have over 160 partners of tribal colleges, Native organizations, tribes, and universities. The Partnerships for Native Health Network consists of six satellite centers across the country: the Pacific Northwest Satellite Center at Washington State University, the Northern Range Satellite Center at University of Minnesota, the Rocky Mountain Satellite Center at University of Colorado, the Plains Satellite Center at Oklahoma Health State University, Southeast Satellite Center at Western Carolina University, the Southwest Satellite Center at University of New Mexico, and the Alaska Satellite Center with South Central Foundation. Some of our research topics include alcohol dependence, substance abuse prevention, smoking and nicotine dependence, suicide prevention, mental and behavioral health, homelessness, high blood pressure, diabetes, stroke risk reduction, cervical cancer prevention, colorectal cancer screening, and cognitive impairment and Alzheimer's disease. The Native Center for Alcohol Research and Education, or NCARE, aims to optimize alcohol intervention research for public health in general and our Native community partners in particular. We accomplish this goal by collaboratively engaging with research project teams and the pilot projects to conduct research that yields high-quality data while simultaneously meeting the unique needs of our partners. And with that, I will turn it over to Dr. Lonnie Nelson and Dr. Susan Collins for a presentation on harm reduction talking circles for the urban American Indians and Alaska Natives with alcohol use disorders. Thank you.
Thank you, Crystal. So our talk today is titled Randomized Clinical Trial of Harm Reduction Talking Circles for Urban American Indians and Alaska Natives with Alcohol Use Disorder. I'll be presenting, actually just introducing, then I'm going to hand it over to Susan, who will talk about harm reduction in general and some specific past research that she's conducted on harm reduction. And then she'll hand it back over to me, and I'll talk about the current project, the HaRTC project. Next slide. Susan? I'm sorry, could you start over because you were muted?
Sure. I just wanted to share a little bit about the origin story for the HaRTC, and then we'll talk about the fusion of harm reduction mindset and HeartSet with the Native tradition of talking circles to operationalize the HaRTC project. We'll talk a little bit, Lonnie will be talking about the pilot experience as well as the current study plan. And we're joined today by our community consultant, Sean Buffalo Mead, who will share his experience as part of our community consultation team. Next slide. So the origins for this story really started in our over a decade-long now research that we've conducted together with the Downtown Emergency Service Center and the good people at 1811 Eastlake, which is a low-barrier housing program within the DESC housing portfolio. And a lot of this work was conducted in the context of a project that is now led by my colleague and the co-director of our Harm Reduction Research and Treatment Center, Dr. Seema Klipasethi, who's pictured here, along with our Life Enhancing Alcohol Management Program, or LEAP, Community Advisory Board. Next slide. So to give you a little bit of background for the environment in which we started to do this work, we were approached over a decade ago by the now late executive director of the Downtown Emergency Service Center, or DESC, to evaluate their 1811 Eastlake Housing First program. This is low barrier, permanent supportive housing that's provided to 75 of King County's top utilizers of publicly funded services, who also had long histories of chronic homelessness as well as severe alcohol use disorder. The controversial part of this housing when it opened in 2005 was that residents were permitted to drink in their units and that there were no treatment or abstinence requirements, which are really typical when you're talking about continuum of care housing, which is up until the last decade been the gold standard of care in terms of housing provision. And in fact, this kind of housing, the low barrier nature of it, was dubbed harm reduction housing. Next slide. And what we were able to show with our evaluation of this housing program was in a series of studies that housing first was associated with really positive outcomes both for the affected individual and the larger community. For example, compared to a waitlist control group, a group of folks who were on the wait list for housing, people who moved into 1811 Eastlake had over $4 million in taxpayer savings over the first year of operation due to reductions in publicly funded service utilization, including the emergency department, emergency medical services, and jail. We also found over the 2 years after people moved into housing, statistically significant decreases in their alcohol use and related problems, as well as reductions in jail days, jail bookings, and significant reductions in EMS use, particularly advanced life support services. What we found in this research was that everyone was really benefiting from the provision of housing, low barrier housing, and there were no statistically significant difference in outcomes between American Indians and Alaska Natives and people who were not claiming American Indian or Alaska Native heritage. Next slide. But as you can see, there are clear disparities between the full population of the house, the general population of 1811 Eastlake, and people who have AIAN heritage. And you can see that despite the fact that everybody is benefiting from low barrier harm reduction housing, that American Indians and Alaska Natives in this housing program still are experiencing a disproportionate level of alcohol-related problems, and that is as measured by the short inventory of problems for alcohol. Next slide. And so the late and great director of DESC, Bill Hobson, I remember him sitting in a meeting and saying, well, ladies, we did it. We showed that it's about housing first. But what comes second? Y'all are the alcohol treatment experts, so you tell us what to do. What can we do to continue to bolster these positive harm reduction effects that we've seen once people move into housing? And honestly, we were kind of at a loss. We really came to realize that we didn't have all the answers, and instead we would need to turn to the real experts, community members living at 1811 Eastlake. Next slide. And what we had learned over the course of our decade of research at 1811 Eastlake and our work together with residents and community members there is that there are a lot of strengths that people bring to the table, things that could really help us alcohol researchers do our jobs better. And these are a few of the strengths that we featured in a qualitative research report back in 2012 that we published in the International Journal of Drug Policy. The fact that people have a lot of really important strengths that we can work together to capitalize on and engage in co-learning to figure out how to make programming that is low barrier but can help people reduce their alcohol-related harm. And it really became for us, how can we honor the wisdom, strength, and lived experience in this community to take our research efforts to the next level and improve services in this setting. Next slide. And so we learned a new way of doing research. We went back to school and worked with Bonnie Duran, who is a well-known Indigenous wellness researcher, as well as a CBPR expert at the University of Washington, and learned a new approach to research called community-based participatory research. In this research, researchers do not necessarily bring their own research questions to the table. Instead, we engage communities to find out what's important to the community. Then we involve community stakeholders, in this case, residents in housing, patients, community members who experience homelessness and substance use disorder, and as well as the community-based agencies that serve individuals in this position. And we involve these community stakeholders more equitably in research design and implementation and evaluation. The idea is that we can better capitalize and leverage all of our stakeholders together, our unique strengths that we bring to the table, and combine our collective knowledge and action to achieve positive, sustainable, and lasting social change. Next slide. And so we created a new research approach. It's a 4-phase research approach that we now apply across the board in our research in the Harm Reduction Research and Treatment Center. In phase 1, we really focus on listening to the community through qualitative interviews and then qualitative data analysis to understand what the different stakeholders feel are the needs that they're facing and how they believe they are best addressed. In phase 2, we develop these approaches that we will then test in phase 3 together with the community. One of our primary vehicles for community involvement is community advisory boards and hiring community consultants to represent community members' voices in our research team meetings. In phase 3, we then enact these approaches and test their effectiveness using mixed methods designs and some kind of controlled trial. And in phase 4, we focus on disseminating and implementing these programs sustainably so that we're not engaging in helicopter research, but are really truly trying to create transformative, sustainable, and desirable change for communities. Next slide. And so in phase 1, what we learned when we talked to folks at 1811, we spoke with 44 resident participants, and we did focus groups with staff and management as well, but I'll focus on what residents were telling us they wanted to see happen. 22% of our participants were women, which is very typical for this population, with a mean age of 53 years. This is of particular importance because the mean age of death for this population in King County is 50. 9% of the population we were working with is Latinx. And as you can see from the pie graph, 21% of participants in this part of the study claimed American Indian, Alaska Native, or First Nations heritage. And all but 2 of the 21% of people who said that they identified with more than one race also said that one of those races they identified with was American Indian, Alaska Native, or First Nations heritage. Next slide. So what we heard across the board from all participants was that harm reduction was the only thing that works. In fact, they appreciated low barrier housing and the low barrier case management approaches that were applied already, saying that it was largely what saved their lives. At the same time, what we heard from this largely American Indian and Alaska Native sample was that there are certain needs that Native communities have that are best served by people who represent their interests, so having more Native staff and having more culturally appropriate practices, ways that people can reconnect with their culture and also their spirituality. And that led to us wanting to develop culturally appropriate programming through the Life Enhancing Alcohol Management Program. Next slide. So combining these two approaches, one piece of this was the desire for harm reduction approaches. And this is an alternative pathway to recovery that does not require abstinence or use reduction. It refers instead to a low threshold and user-driven set of compassionate and pragmatic approaches that aim to reduce substance-related harm and improve quality of life for both affected individuals and their larger communities. Next slide. And so through the LEAP, we've enacted various types of harm reduction programming. There are leadership opportunities for people to be able to steer and guide program development and implementation at the house. There is a panoply of meaningful activities, and there is a group of recovery and healing pathways that we co-created together with residents. And one of these was a talking circle, which was explicitly mentioned by our resident participants as the key culturally appropriate intervention that they wanted to see enacted in housing. Next slide. And so I'll hand this over now to my partner in science and in life, Lonnie Nelson, to talk a little bit about how talking circles were piloted in this housing program.
Thank you, Susan. So when Susan initially came to me with this request and explained that she wanted me to facilitate talking circles with residents at 1811 who may be intoxicated, I said, I don't think you can do that. And so she offered to put me in contact with some gentlemen that she had as guest speakers in a class that she had taken on native pathways to health at the University of Washington School of Medicine. And we got together and together with Abigail Echo-Hawk, had an afternoon-long meeting with these gentlemen where we discussed their ideas on the topic and how we might be able to provide talking circles, even though they were ceremony, for this population who may not be abstinent. Because as most people know, drugs and alcohol have no place in ceremony and native culture. And what we arrived at was that the following model would still be acceptable to conduct with these folks. If I were to begin with introduction to the practice, laying the tradition out, explaining to everyone who was in attendance what the expectations were. That being primarily that there would be a talking piece. In our case, it was a feather that would be passed around the circle, and that only people who were holding it at the time were to be speaking, and everyone else should do their best to be present and fully listen to that person sharing their truth. And the piece would continue to go around the circle until there was nothing left to be said, and people were I guess, content with what they had shared. And then generally there's a spontaneous expression of gratitude that's not really explained when you're laying out the tradition, but it just happens. And then closing the circle with another round of smudging. And so they begrudgingly gave me permission to do this with this group at 1811. And so we did it twice a month for 4 months, I think. Next slide. Oh, right. I forgot to mention that, so it's a good thing the slide is here. Given that these folks, were in this harm reduction housing setting, and that they had shared through the LEAP interviews that they felt that harm reduction was an important approach, that I was to try and incorporate themes that related to harm reduction in the introduction to the practice that we shared, and the initial jumping off point as the talking circle keeper, the role that I was playing. And so, one of the sessions focused on approaches to self-care and just how to take care of yourself and be healthier in the context of living in a non-abstinent way. Another one was the session that we held on Veterans Day, I believe. We talked about what it meant to be a warrior and to keep yourself and your community safe, and in the context of substance use in that housing setting. So these are just a couple of examples of harm reduction topics that were integrated into the talking circle practice that really, I guess, embodied this merging of the talking circle practice with a harm reduction approach. Next slide. So this is where I had been going. We did 8 of these sessions. 23% of the residents in the housing project attended at least one. We had an average of about 6 participants per session. Yeah, these are some of the topics that I was talking about before. It was a really particularly interesting session was the one about what does it mean to live in a good way? Because, you know, in Indian country, we have this expression to do something in a good way. You know, that's how we all want to conduct ourselves. And it was very interesting to hear the perspectives shared by the residents about what that meant for them and their context. It was a fascinating session. And participants really seemed to get a lot out of it and enjoy it. You know, people saying things ranging from, you know, it was a beautiful experience to, you know, gave them a chance to reconnect with their native culture. One participant noted that it was a hell of a lot more useful than an AA meeting, which I thought was a colorful but complimentary comment. Next slide. So with that pilot information sort of in hand, Susan and I decided that we should do an evaluation of this. If this is going to be a thing and we were going to do this, we should know sort of what the effect of it might be for people who participated in it. And IREACH was putting in this center grant that Crystal introduced earlier. So we decided to write our project as one of the component projects within that center grant as a mechanism for studying this intervention. And to do that, we partnered with Seattle Indian Health Board, and they had some great suggestions on sort of how they would like to see the talking circles implemented. And we'll talk a little bit about that as we go on. Next slide. So Susan introduced the multi-phase structure before, and we are currently in the first phase. We've completed 30 participant interviews, 5 management leadership interviews, and then we'll be doing the staff focus groups in December. And then we'll take all of that information and integrate it with the help of our community advisory board to develop the specific manual that will be used to carry out the harm reduction talking circles in the clinical trial, which will be in phase 3 that we hope to get started in late spring of 2019. Next slide. So I did mention this. I guess the only thing to note that I didn't say before here is that the method that we'll use to analyze the qualitative data is we're going to conduct a conventional content analysis and identify themes and points for optimal adaptation of the practice with that community input from the patients. Incidentally, the patients that we interviewed from Seattle Indian Health Board were individuals that would meet criterion for participation in the eventual clinical trial. So these were urban natives who were patients at Seattle Indian Health Board, primary care or behavioral health, who had a history of alcohol use disorder and were not currently completely abstinent in most cases, although some were. Yeah, okay, on to the next slide. In phase 2, we will continue to assemble the CAB. We have 2 community advisory board members recruited from the patient sample. We'd like to get a couple more on board. We also have one of the traditional healers that we consulted with way back at the beginning of this process that I shared with you about earlier, who's going to be joining the community advisory board. His name is Mr. Sam Watson-Albin, maybe watching out there today. If so, hi, Sam. We will then, with their assistance and some members of the Seattle Indian Health Board leadership, review the qualitative findings and come up with the themes that are going to inform the manual for the harm reduction talking circles, refine and finalize that manual with the CAB, and then we'll do some pilot sessions using that manual as a guide and sort of training the traditional Indian medicine practitioners from Seattle Indian Health Board who are planned to be those to deliver the actual intervention during the clinical trial. Next slide. And the clinical trial is going to be, of course, our phase 3. And the aim is to evaluate harm reduction walking circle effectiveness in comparison to services as usual control group. Typically for the other alcohol use disorder services, they require complete abstinence, and that puts off a lot of people who don't feel that they are either ready or willing to completely stop using alcohol. Maybe they want to modify how they're doing it, change their patterns, but they just don't feel comfortable with complete abstinence at the time. And those are the folks that we are going to be planning to include in our clinical trial. It's going to be a 2-arm, partially nested, longitudinal RCT, looking at HaRTC versus services as usual, with baseline 3 and 6-month follow-up assessments. The analysis plan is a multi-level structural equation model that Susan's going to do because she is far more advanced statistically than I am. And the participants are planned to be 280 Seattle Indian Health Board patients meeting criteria for current alcohol use disorder. The primary measures, our outcomes are going to be peak alcohol quantity, frequency, and alcohol-related harm using the SIP for alcohol that Susan had mentioned earlier. We're also going to get ETG, creatinine ratio, to look at liver functioning, and measures of not just health-related quality of life, which is what the EQ 5D5L measures, but also more general quality of life. So we have 2 quality of life measures. And then finally, we're going to be able to look at cost effectiveness through help from the health economist who's on the investigative team for the Native Center for Alcohol Research and Education. Okay, thanks. As I mentioned before, we have completed 30 individual patient interviews. We got 1 key informant interview left to go. Had trouble getting that one scheduled, Abigail. Assembling Community Advisory Board at the Seattle Indian Health Board is underway, and we are beginning our phase 1 qualitative data analysis as we speak. Okay, so we do have a community partner who had just stepped out a few minutes ago, but hopefully he'll come back in and can share his perspective. He's one of our community advisory board members. So we'll go ahead and take questions until he returns. Gladys?
Yes, we're going to head over to the chat.
Okay, so how this is going to work is they're going to open up the chat feature if you want to type your questions into the chat box. Then I'll go ahead and answer some of those while we wait for Mr. Bucklow-Mead to come back to the office here.
Are all of the circle keepers as part of the study of Native descent?
That is my understanding. Seattle Indian Health Board's Traditional Indian Medicine Program contracts with local traditional healers for their services as deemed necessary by their Traditional Indian Medicine Coordinator, Itai Jeffries, who does the initial interview with people who want to access those services to sort of determine what kinds of things might be helpful for them. And then they contact local Native healers who may have specialties in the area of need for that individual. And so, yes, the circle keepers will be of Native heritage, most likely primarily from the Pacific Northwest.
We have another question. So what are your biggest challenges for this study/trial?
I would say probably the biggest challenges are currently are how to ensure the cultural authenticity of the practice. And I mean, it is ceremony, and attitudes regarding alcohol in Indian country vary pretty widely, and some folks actually consider it to be an evil spirit. And so how would you then conduct ceremony with an evil spirit in the room? Should a person come to the session intoxicated? How will that work? And frankly, we're trying to work through that with the group that we're going to be hopefully drawing from to conduct the sessions here in the near future. Really looking forward to that. I think it's going to be an incredibly interesting conversation. But that seems to be the main barrier at this point.
We have a third question. So will data be collected during the talking circles? And if so, how will it be used?
There won't be data collection done during the talking circle. The only data collection that, so there won't be data collected for analysis during the talking circles. They will be audio recorded so that we can review them with the circle keepers and just do a fidelity check to them to make sure they're adhering to the manual that they're going to help write. So it's not like anybody's going to be telling them what to do, just to be clear. But that's the only data that will come from those, and those audio recordings will be destroyed immediately after they've been used for the purpose of fidelity monitoring. So there won't actually be data collection during the talking circles, only at the baseline and then follow-up assessments.
Great. We have another comment/question. So thank you for a great presentation. I'm wondering if in some of your qualitative data collection, if themes have emerged regarding cultural identity as a concern for stakeholders, and if that is something you have considered measuring as a potential outcome.
Yes, we are actually going to be administering the American Indian Enculturation Scale, which is a measure of participation in Native culture, and we expect enculturation to increase as a result of participating for patients. Okay, Mr. Buffalo Meat has joined us, and Sean, I'm hoping that you'll share with everybody what your experience has been like being part of the Community Advisory Board, and if you want to sit in front of the camera.
Should I introduce myself?
Please do.
Yes, my name is Sean Buffalo Meat. I am part of the Sac-Fox tribe of Oklahoma. I've been here for like 17 years, and it's been an involvement with the program that allows me to find a resource to have a place to go when there was no place to go. And I am a resident of 1811 Eastlake. It's a low-income building that houses people with disabilities and people coming off the streets and trying to assimilate back into the world of being homed or housed and an environment where you have a resource for different opportunities of help. And there's a program called LEAP that has a activity with Susan Collins, and I've been a part of that group, and they involve activities for yourself and for a distraction, in my opinion, on alcohol and drug abuse, and in the manner of a supplemental resource to say, hey, I can find help right here. But at the same time, this branch that went off into the research from the University of Washington and other colleges and entities such as the Health Board, C.L. Linden Health Board, that I am a patient of, and it's just another resource from the C.L. Linden Health Board allows the Native American community to come together in a sense, in a spiritual manner, because a talking circle that is being organized right now is definitely going to make a difference within the community, becoming an unusual and first-time effort, excuse me, to allow people that have I would call it a disability of control of their alcoholism or drug addiction. And it allows you to open up and be a little bit more safe in an environment that's private an environment that's what's the term? The doctors, the counselors, the psychologists, and the doctors that are trained to do that are there to help you. But it's a well-organized approach to the community, and it's been kind of in dormant as far as exposure, I think. But I been just wanting to advocate as much as I could, and 60 interviews have been done or such? 30, and that makes a difference already because the word's out now, and that gives me the freedom to share this information about the resources. But I could see how it could make a difference within other communities, other Native communities throughout the country. I've always had the opinion to target the people coming out of high school, because personally, that's when I began, because I didn't drink until I was 18. And I hope I'm on the same page with this interview. I don't know how much time I have, but this resource is unusual, so much that, I don't ever remember anything, this open, this unusual approach in research for the Native American community, because it will affect their traditions and spirituality. And it involves the spirituality to make a native feel comfortable, because most traditional natives that grew up around ceremonies and such, alcohol and drugs are prohibited, but this isn't a tribal ceremony. It's a resource. It's a shelter, I believe, where you can find information, you can find help, and you're in a private, real, intelligent, professional environment within the talking circle. And I believe it'll make a difference within the community, because it also allows other people to see the difference in the people that maybe go to these talking circles. Maybe they could have the pass it on effect of, hey, this is a good place to go. And I believe it to just make another resource, because there's a lot of resources out there for treatment. And I see this as a real casual approach instead of direct, coming at you or you coming at them direct and saying, okay, lock me up for 45 days and see how it goes. Well, this is forever. It's the rest of your life, I believe, because you can take this part of the talking circle's message, with yourself, and I believe in prayer. So in writing, I believe, letting things out in an honest form of how I feel, what I learned, and positive things. I remember going to France as an exhibition tribal dancer, having an alcohol problem, but I was also a diabetic. So I had to drink half a cup of water and half a cup of beer to reduce my alcohol use. But that is a reduction. It took the diabetes to make me change, but it doesn't have to be that extreme. And getting that message out to everybody who isn't like going into shock like I did, it gives you like a comfortable approach. It's your choice. They're not telling you to do that. And just like other treatment programs, outpatient, inpatient, that's your choice. And that's the way it's kept. I believe it always will be that way, because you can't force anybody to do anything. And I just, go ahead. No, I'm sorry. I'm looking at the camera and I'm looking at Lonnie and I'm wondering, because normally we talk in the talking circles of the meetings of HaRTC, and where everybody needs to open up on the floor and so forth. And we have direct, that's what I was mentioning to my friends. I said, it's nervous to be talking to nothing. And there's a camera right in front of me going somewhere. So as a native, that kind of, freaks me out too. The last time I felt more comfortable. I don't know what it was. I think it was Joey made me feel at ease. Nonetheless, I'm doing the best that I can, and I hope this makes a difference because I am basically a patient of this learning process of the talking circles and the Seattle Indian Health Board and HaRTC. And as I understand the message, is to allow you to be yourself and come in and receive some help from some professional guidance, but it's going to be your choice. And I believe it's going to be open. Talking circles, as other talking circles have always been open. And I believe it to be a good resource of the HaRTC program of talking circles at the Health Board.
Thank you so much, Sean. Are there more questions?
Thank you.
Thank you, Sean.
They may be for you too, so hang on.
There's one more question. So the question is, can you talk a little bit about the ceremony for those of us who are unfamiliar? So the ceremony of a talking circle.
Okay, I was adopted by my grandpa and grandma, and they were Cheyenne Arapaho people, and Cheyenne had a ceremony of the Sundance people in the Southern Cheyenne. There's Northern Cheyenne and Southern Cheyenne. And then growing up in an environment of a spiritual world of traditions that's been handed down are respected in the manner of coming together in a holy spot. And I believe this talking circle that's being organized is holy in a manner of help and need from that great positive spirit of this source.
Can you describe what the ceremony is like for people that aren't familiar with it?
Yes, there's procedures that are rituals in a sense of taking time, like the Native American church people that my grandfather was involved with. My grandmother was involved with the Sundance ceremony, and my grandpa was a peyote ceremonial holy man that traveled throughout the area praying together with other spiritual people. And there's a ritual, the sun setting is entering, and sun rising is the completion of the ceremony overnight. And there's songs that are sung, and everybody is private in this time of the sun down to sun up. So this holiness and reverence in that spiritual circle is involvement of spirits that are positive and getting rid of bad spirits. Just like any other traditional ceremony, I believe, throughout the world, that in that time, even the Navajo people have a private sand painting ceremony that is very reverent. And you're just raised that way as a child. And so you have that innate familiarity to a holy spot, a holy place. And you give reverence already. You go in pure and you come out pure. And this approach is allowing you to, I'm sorry, I'm getting off the ceremony part, but it is a relationship of the talking circle. But reverence is kept, and there are traditions throughout that ceremony, and it's quiet, and you keep bad things away, without expressing them, because the spirits are watching over you as the ceremony is done. That's been handed down from generation to generation, and maybe it's in my DNA to be familiar with spirituality in the sense that you're just familiar to becoming a part of the ceremony, and it's very reverent and very private and holy.
Excellent. So there's a couple more comments. The person said, thank you very much for the explanation. And another person said, you're doing great. Thanks for sharing your story. We have one more question on the screen right now. What guidance would you give to others who may want to add talking circles to their treatment or prevention programs? Who can lead talking circles?
The traditional way I was raised up is having the blessing and help of an elder going to an elder and asking, about wisdom to have the blessing of this involvement with yourself, the Great Spirit, and others that are willing to come together and meet and join each other in getting help and strength. Did I leave something out? Oh, fry bread. I got to put a plug in. Fry bread is always good, too. It's a good incentive for talking circles.
Yep. Okay. Okay.
Thanks to all of you for joining the first of our webinar in our NCARE webinar series. Please stay tuned for our next webinar that's coming up on January 31st, 2019, from 12 to 1 p.m. It will be on contingency management with Michael McDonald at Washington State University. So we will be getting a registration link up shortly, so stay tuned for that. Keep an eye out on listservs and emails. Also, keep an eye out for your email inbox in the next 24 hours as we will send a survey, a post-webinar survey for you to fill out so we can get feedback moving forward on this series. Again, thank you for attending, and we hope to see you in January.